Hi everyone, I'm Shani Naomi Whiteman. Today I will be reviewing a 2016 randomized controlled trial titled Selenium Supplementation Could Restore Euthyroidism in Subclinical Hypothyroid Patients with Autoimmune Thyroiditis, looking at whether selenium supplementation can restore normal thyroid function in patients with autoimmune subclinical hypothyroidism. I'll be reviewing the background, study design, results, limitations, and clinical relevance. Autoimmune thyroiditis, also called Hashimoto's thyroiditis, is a common cause of thyroid dysfunction. These patients have thyroid autoantibodies such as TPO antibodies and thyroglobulin antibodies that attack thyroid tissue. Some patients develop subclinical hypothyroidism where TSH is elevated, but their free T4 levels are still normal. Many of these patients have mild or no symptoms, and not all of them progress to overt hypothyroidism. And because of this, treatment is debated, and in many cases, clinicians simply monitor these patients rather than start them on levothyroxine, and this creates interest in therapies such as selenium that may help support thyroid function. So according to the study by Pirola, selenium is involved in thyroid physiology and has been studied as a possible supportive therapy in autoimmune thyroiditis. Some earlier research suggested that selenium may reduce thyroid autoimmunity, but findings have not been consistent. And because of these mixed results, the authors wanted to clarify whether selenium supplementation could actually restore euthyroidism in patients with subclinical hypothyroidism due to autoimmune thyroiditis. So the purpose of this study was to determine whether selenium supplementation could return patients with autoimmune subclinical hypothyroidism to a euthyroid state. This was a prospective randomized controlled trial carried out in an outpatient endocrinology clinic in Italy. The treatment lasted 4 months. So using the PICO framework, the population included adults with autoimmune subclinical hypothyroidism. The intervention was 83 micrograms per day of selenium. The comparison group received no selenium and no placebo, and the primary outcome was normalization of TSH to 4.5 or below. The study enrolled 196 adults, and 192 of them completed the full 4-month trial, with 96 patients in each group. To be included, patients needed to have subclinical hypothyroidism with positive thyroid antibodies confirming autoimmune thyroiditis, and they also had to have normal free T4, which confirmed the condition was subclinical. Patients were excluded if they already had overt hypothyroidism, if they were pregnant, had chronic systemic illness, or if they were taking levothyroxine or any other medication that could interfere with thyroid function. This helped ensure that the changes in thyroid levels may be attributed to selenium alone. The selenium group received 83 micrograms selenium a day for 4 months, and the control group received no supplementation. Neither group was on levothyroxine, which means any change in thyroid function can be linked directly to selenium or its absence. So after 4 months, the researchers measured how many patients returned to euthyroidism, which was the primary outcome. They also measured changes in TSH and changes in thyroid autoantibodies as secondary outcomes. The primary goal was to determine how many patients returned to a euthyroid state after 4 months. In the Selenium group, 30 out of 96 patients reached a normal TSH, which is about 31%. In the control group, who didn't receive selenium, only 3 out of the 96 patients became euthyroid. This difference was statistically significant with a p-value less than 0.0001. This shows a clear benefit of selenium supplementation in restoring euthyroidism in these subclinical hypothyroid patients with autoimmune thyroiditis. Among the selenium responders, TSH decreased from 5.88 to 3.21, with a p-value less than 0.0001, showing a statistically significant improvement. Their thyroid antibody levels also decreased significantly over the 4 months of supplementation. In contrast, patients who did not respond to selenium and patients in the control group showed minimal or no improvement in hormone levels or antibodies. These findings support the primary result by showing biochemical improvement in the selenium group. The study had several strengths. It was a randomized controlled trial, which is a strong design for evaluating an intervention. The primary outcome was clear and clinically meaningful. The data was based on objective lab values rather than subjective symptoms, and the dropout rate was very low, with only 4 patients not completing the study. However, the study had limitations. The sample size was relatively small, and the study only lasted for 4 months. So we do not know whether patients remained euthyroid long-term. The control group did not receive a placebo, which may introduce some bias. And without long-term follow-up, we cannot really tell whether selenium must be continued to maintain this improvement. There are parts of this study that don't completely apply to our patient in case number 3. First, Pirola included only patients with subclinical hypothyroidism, while our patient had clinical symptoms, including weight gain, fatigue, cold, sensitivity, and hair loss. Second, none of the participants had ever taken levothyroxine, whereas our patient had used it and felt better. So her treatment history is different. The study also focused only on lab outcomes and did not assess symptom relief or quality of life, which are very important for our patient. The trial only lasted for 4 months, but our patient requires long-term management, especially because she hopes to have another child. And finally, the participants in this study were treated in a general outpatient setting, but our patient's situation includes cultural factors and a high level of distrust towards healthcare outside the reservation. These elements may influence how acceptable a treatment plan is for her. The authors concluded that selenium supplementation restored euthyroidism in about 31% of patients with autoimmune subclinical hypothyroidism, compared to only 3% in the control group. Selenium was well tolerated and no major adverse events were reported. Based on these results, the authors suggest that selenium may be a useful therapeutic option in these patients. In my view, selenium seems like a reasonable option for some patients with autoimmune subclinical hypothyroidism, especially individuals who want a more natural approach or are hoping to delay long-term levothyroxine therapy. That said, the study was short and didn't look at symptom improvement or what happens over time, so patients would still need close follow-up. I see selenium as something that could be added to a broader treatment plan with regular monitoring of thyroid labs and symptoms. Thank you for listening. These are the references I use for today's presentation. Thank you again.